Hey, what's up? As a continuation of the previous video, in this one we deal with some delicate questions that usually arise at the end of a loved one's life. The goal is to help you have a general knowledge that will help in your conversations with your doctor. It means that every effort will be made to keep vital organs functioning in someone who is dying. For example, mechanical ventilation may be used to help the patient breathe, or dialysis may be started if the kidneys are failing. The purpose of this life support is to allow the organism to recover, not to use it indefinitely. Cardiopulmonary resuscitation or CPR can sometimes restart a stopped heart. It works best on people who were previously healthy, broadly speaking. During resuscitation, the doctor presses rhythmically on the chest with great force, and every so often breathes air into the lungs, or resorts to electric shocks applied with a defibrillator to correct an abnormal heart rhythm, and administers medications. I'm sure we've seen these maneuvers in some movie. What you don't usually see are broken ribs or even the collapse of a lung resulting in manual resuscitation maneuvers, which require about 50 kilograms of pressure and sink the chest about 5 centimeters. It is very difficult for resuscitation to be successful when applied to older people with multiple chronic illnesses or who are already very frail. If a patient has very severe breathing problems or stops breathing, a mechanical ventilator may be necessary. It forces the lungs to function. To do this, the person must be intubated. That is, a very uncomfortable tube must be passed into the trachea, which, in turn, requires sedation with very powerful intravenous drugs. And sometimes the person is tied up to prevent the tube from being removed. If the situation lasts for several days, the doctor may suggest a tracheotomy to connect the ventilation tube through it. This is more comfortable for the patient, and even sedation can be removed. However, the procedure also carries risks, such as a collapsed lung, blocked tracheostomy tube, or bleeding. Once the decision has been made, it is advisable to transfer it to the doctor in charge so that he can write down in the patient's file the acronyms that correspond so that CPR is not practiced. No CPR, do not resuscitate, do not intubate, or allow natural death. A particular case is that this care takes place at home, for which it is important to have a document signed by the doctor and in a visible place in order to ensure that the emergency medical personnel who might intervene will respect this decision. Without this document, medical personnel are required to perform resuscitation maneuvers. The document does not stop all treatment. It only serves to avoid the cardiac massage or the mechanical ventilator. By the way, these orders are not irremovable. They can be revoked if the situation changes. A pacemaker is a device implanted under the skin in the chest to ensure regular heart rhythm. It won't keep a person who's dying alive. Another thing is the implantable cardioverter defibrillator, which is also placed under the skin, and by means of an electric shock returns the heart to a regular rhythm when needed. This device should be turned off when life support is no longer required, and by the way, whatever the device, it must be removed if the remains are to be incinerated, in order to prevent explosions. If a patient is unwilling or unable to eat or drink, the doctor may suggest a feeding tube. It makes sense to facilitate recovery from a disease by temporarily ensuring nutrition through a tube, but at the end of life, the tube may be more uncomfortable than not eating. And it is known that, in people with dementia, it neither prolongs life nor prevents the accidental aspiration or inhalation of food. It must be understood that, when death approaches, loss of appetite is very common. The body's systems begin to stop functioning, and liquids in food are no longer needed as before. In fact, Some experts believe that few nutrients are absorbed at this stage, regardless of the type of food. In addition, once the catheter is inserted, the family may have to decide when to remove it. If tube feeding is to be attempted, there are two methods that can be used. The first is the nasogastric tube, which, as its name suggests, runs from the nose to the stomach, and is intended to be used for a short period of time. It may be uncomfortable for the person to try to tear it off, so it would be necessary to tie him/her up. This, in addition to undermining dignity, can lead to a whole series of complications arising from immobilization. The other type of catheter is percutaneous endoscopic gastromia, which reaches the stomach directly through an opening in the side or abdomen. It carries risks of infection, pneumonia and nausea. Given the options, perhaps assisted oral feeding, that is, feeding, is not such a bad idea, especially in people with dementia. The doctor may suggest sedating someone who is dying to control symptoms that are not responding to other medications, and that still make the patient uncomfortable. This involves using medications that leave the person in a state that resembles being asleep, although he or she can hear. So it will be a good idea to keep talking to her instead of talking about her, and to avoid conversations we wouldn't want her to hear. Sedatives may be stopped at any time. In addition to sedation, your doctor may suggest other medications to control pain and ultimately provide comfort. As we know, antibiotics are used to fight bacterial infections. They are common in older people who are dying from respiratory infections of the lower tract, such as pneumonia, or the urinary tract. Like any medicine, antibiotics have adverse effects. So, as always, a risk-benefit balance must be made. But in general, if the infection has appeared when you are already dying, antibiotics probably won't prevent death, but they might make you more comfortable. And so far for today, I hope I've been helpful. In the next video we will discuss how to deal with situations where what the doctor suggests differs substantially from what we prefer. Thank you very much, and see you in the next video.